Good evening, ladies and gentlemen. We welcome you to the Royal Albert Hall for the Journal of Wound Care and World Union of Wound Healing Societies Awards 2020.
Well, the category this evening is the Innovation in Surgical Site Infection Award. And to read out the nominees, I'd like you to welcome to our virtual world, Rod Hume, who's Global Product Manager from Essity.
And so, on the shortlist, we have the International Consolidated Wound Infection Guideline Task Force, Association of Advancement of Wound Care, USA. Acute and chronic wound infections create clinical, economic, and patient-centered challenge, best met by multidisciplinary wound care teams providing consistent, valid, clinically relevant, safe, evidence-based management across settings. The final ICWIGTF review of best evidence supporting each recommendation, the complete guideline was compiled and made accessible at aawconline.org. The second nominee is Dr. Kylie Sandy Hodgetts, Senior Research Fellow Director, Skin Integrity, Clinical Trials Unit, University of Western Australia. Kylie's work has contributed to understanding awareness and solutions for diagnosis of surgical wound complications such as dehiscence, a conceptual framework for patient assessment, a risk assessment tool for prediction, and a new grading system for dehiscence are new to the clinician's armamentarium for patient management. Furthermore, this work led to the establishment of the International Surgical Wound Complications Advisory Panel to raise awareness, educate, and advance the field. And the third nominee is Roberto Casino, MD Geriatrician, Medical Director, Antiseptic Effectiveness of a Dressing Containing Ozoil in the Post-Surgical Treatment of Wounds. Casa de Ripiso Residencia, Sacra Familia, Korean Bagal Arceral Company, and creator of the patent Ozoil Stabila Ozonidis with vitamin E acetate, Italy. Rigonoma in form of spray, cream, and gauze with Ozoil is an innovative dressing and device for the prevention and treatment of acute and chronic skin lesions of different etiology. The aim of his work was to demonstrate that it is possible to avoid new surgery without risk. The research protocol involved treating each patient 3 times a week with a dressing containing Ozoil. All wounds showed a significant reduction in size whilst overcoming infection, and pain was also improved. And now to the results. So the innovation in surgical site infection. The winners in reverse order are: in bronze finalist place, Roberto Casino. Congratulations, Roberto. In silver finalist place, the International Consolidated Wound Infection Guideline Task Force. Congratulations to you too. And in gold medal place, Dr. Kylie Sandy Hodgetts. Please welcome Dr. Kylie Sandy Hodgetts to the stage. Congratulations to the winner, Kylie.
Thank you. I'm absolutely humbled and delighted. I'd like to acknowledge my fellow nominees. It is so important to conduct research in innovation in surgical site infection and ensure that we are impacting patient-related outcomes. I'm absolutely honoured to receive this award. Thank you. Good evening, everybody. I'm Dr. Kylie Sandy Hodgetts. I'm a Senior Research Fellow at the University of Western Australia in the School of Biomedical Sciences. I'm also Director of the Skin Integrity Research Institute in Western Australia. What I enjoy most about my role is the scholarly pursuit of research. I have a privileged position where I can pursue scientific research in the field of wound care and work with clinicians and allied health professionals and patients to improve healing outcomes for post-operative incision care for patients. I love working with others and sharing ideas and watching others succeed as well too, but more importantly is making a difference in patients' lives, and I'm very privileged to be able to do that. 2020 has been a very interesting and challenging year, not only in Australia but around the world. What it's taught me more than anything is the importance of empirical scientific research and how everything must be underpinned by evidence-based practice. We need to ensure that we continue with rigorous academic research and that science plays a key role in how we manage and improve patient lives. And I think with the COVID pandemic, this has really brought scientific endeavours to the fore like nothing we've really never seen before globally. So it's taught me the value of what researchers and scientists do and how important it is for patients. The work that I've achieved over the last 4 years is done by a multidisciplinary team approach. I've established a conceptual framework for patient assessment for surgical wound complications, in particular surgical wound dehiscence. I've also developed and validated a risk assessment tool for prediction of patients at risk of surgical wound dehiscence. There's a number of other studies that I've pursued, but probably what's led to this has been the establishment of an international organisation whereby the research can be translated and shared with others. So it's a body of work and it's still growing and it never stops. But that's probably the key achievements that have led to this award. Make friends, have a passion about what you're doing. If you're not passionate, it's not going to sustain you over the long term when things get really hard. But if you feel that you're making a difference, keep going. Reach out to others if you need help. Don't be afraid to ask. And you never stop learning. Life presents so many different opportunities, so ensure you grab them with both hands and make the most of them. That's probably what I would recommend.
Welcome to the first webinar, The Importance of Innovation in Surgical Site Infection, in conversation with Karen Owsey and Claire Kilpatrick. Before we start our webinar, here is a short presentation from Rod Hume, Global Marketing Manager for Essity.
Hi, my name is Rod Hume. I'm Global Product Manager for Wound Care at Essity, based in Hamburg. And my role is to understand how Essity can help improve patient health and outcomes, specifically in the wound care area. Essity is a health and hygiene company which is headquartered in Stockholm in Sweden, with approximately 44,000 employees around the world. And we cover several segments such as professional hygiene, with the brand names of Tork, well recognized, personal hygiene, the brand name Tena, pretty well recognized, and medical solutions such as incontinence and wound care. And that's where my focus is. The overall, so two of the core values of Essity are around caring and collaboration in the interests of health and well-being. And one of our key roles within industry is to collaborate across the wound care sector to improve delivery and best practice. And we feel that the award is one way that we can encourage others to advance best practice through innovation. We picked surgical site infection. There's a full range of Journal of Wound Care awards, and it's great that you recognise lots of different segments. But for surgical site infection is one area where we think we can help, and we also feel there's an area that's still more work needs to be done, despite a lot of the efforts over recent years, and particularly because of the risk of infection, but also the risk of antimicrobial resistance that is getting darker and darker, and that's where very much where Essity across the whole of our organisation feel that we need to help as well. And that's why we think it's important to recognise not just SNI innovation, but innovation across wound care as well. I think clearly, everybody's in the same situation here, and I think what is recognised from Essity is the importance of everyone and making sure everyone's safe. So that we have a very strong duty to do that. But probably one of the most important things that Essity do internally is supporting colleagues and their families to make sure they feel safe and strong enough to carry on with their roles, which is supporting the front line and supporting healthcare workers and healthcare organisations to deliver what they need to do. Perhaps one example where we have sort of changed something within there is that we've actually converted one of our manufacturing lines in Gothenburg, which made some of our incontinence products. We've converted it to make masks. So we now actually provide masks, and yes, there's other companies doing the same, which is great. And that is, again, one strong reflection of this whole situation because of the pandemic, is everybody come together for the benefit of everybody else. Within sort of this specific area, we still strongly feel that there's a big threat from antimicrobial resistance, and we think that dealing with surgical site infection is a part of that. And we don't profess that we can do everything, not at all. Everybody will play their part, and we think we can help in the area of SSI reduction. So that's where we want to emphasize this part here. And again, it will continue to be a challenge. So we'll carry on exploring this area and working with whoever we need to help patients and healthcare workers on the front line. I'm quite lucky. I've been in wound care for quite a few years. My colleagues will tell me maybe far too long, but I think it comes from collaboration. It comes from passionate people who bring the right resources and the right practices together at the right time in the best interest of the patients, their family and public health. Now, that sounds like sort of, pardon me, a written statement, but it is, that's what it's about. Again, I see it from my colleagues that I've worked with over the years, the passionate people who come together with healthcare professionals to deliver new things that change outcomes for patients. And look, when you see that patient smile and they say thank you, that's when you know it's working. To me, that's what excellence brings. It'll never stop. And we should always keep on improving because, there's an evolving situation, evolving environment. But that's what I believe excellence is, keeping on improving on what we've had.
Hi, and welcome to In Conversation With. Today, we're very pleased to invite Professor Karen Uzi, Director of Skin Integrity at the University of Huddersfield, and Claire Kilpatrick, Director of S3 Global and a consultant to the World Health Organization. Today's topic, we're going to have the importance of innovation in surgical site infection. When we last met, we were at the European Wound Management Association conference back in November. We chatted about the importance of antimicrobial stewardship in reducing the risk of antimicrobial resistance. And we had a good, strong conversation then. Today, we're going to be more specific about surgical site infection. And I'd like to have a conversation and some questions to you to explore this for the audience today. Thank you. My first question, and perhaps I'll come to you first, Karen, is why is innovation important in surgical site infection?
It's a good question, Rod, and it will be a long answer, probably. I think a lot of it is because for many years, well, for decades, we've focused on chronic wounds or hard to heal wounds, and everybody's talked about pressure ulcers, leg ulcers, diabetic foot ulcers, and we've had all this innovative practice, but we've forgotten about just your normal bog standard surgical sites. People go into hospital every day, or used to go into hospital every day and have elective surgery, and then would have obviously a surgical site incision. But we just seem to think sometimes that, we'll give the patient the operation, the wound will be sutured, stapled, whatever it is, and everything will be fine. But we don't often think about a surgical site infection at the end of it, or surgical wound dehiscence, or peri-wound maceration, whatever may happen because of the issues to do with surgical site. So I think one of the biggest innovations that we need to see is more education and highlighting the importance of people taking surgical site wounds a little bit more seriously and putting a lot more effort into ensuring that we prevent complications and being able to identify at an early stage wound infection as well. So rather than waiting, because generally the patient will have their operation and they'll go home after a couple of days, if not the same day. So how do we inform the patient and their carers what to look for? So rather than waiting for immense pain, for the temperature to go up or to see redness around the wound, is to tell them this is what we want you to look for, this is how to look for it, and this is who to speak to if needed. And maybe something that's really easy. So give them some charts where they can see different pictures of wounds as well, just so that they understand what they're looking for.
Okay, good. Thank you very much, Karen. Claire, what's your view on the need for innovation?
Rod, as you know, Karen and I love to feed off each other and make sure we can stimulate each other to really push on all these different ideas and bring different perspectives. And I couldn't agree more, Karen, about potentially how our clinical colleagues view surgical procedures and then that post-op surgical wound. It kind of sounds that simple when you say it like that. Surgery, admission, surgery, post-op, everything's good. There are actually 29 evidence-based WHO recommendations for surgical site infection prevention. So that's the complete opposite of what it sounds like, and often how our colleagues make it look seamless and the great care and practice they already give, either through the culture and the practices in their own setting or through having implemented these recommendations. But I think for me, what really struck me about this conversation about innovation is that innovation can be classed as anything crucial to continuing success. And I just think it's really important to have all of our colleagues know that it doesn't have to, as you described, Karen, be something really technical or high tech. There are many options. And I love how you talked about post-operative monitoring of wounds, because for me, in all these years, back from when I was doing it in practice through to supporting people in many other countries just now on these sort of projects, we're really seeing some sort of innovative thinking around, as you've said, being able to look at photographs, but apps that actually can be used, very easy, very simple, used in low-income countries as well, to be able to empower those people to be part of that surgical team. So I get quite excited about what could go forward with innovation because it can mean so many things. And for me, for sure, it's all about all of the aspects of how we achieve improvement and how we prevent more and more infections.
Very good, thank you. Just building on that, Claire, you have experience of connecting with colleagues and clinicians, healthcare professionals around the world. What have you seen, observed as far as innovations, exactly, not just technologies, but ways of addressing this topic? Have you got any examples that you've seen around the world that are emerging, either pre-operative, peri-operatively or post-operatively?
I want to probably just bring that point back to what might not sound like an innovation, but it is, and when we think about that pure definition. And what we've worked on with a number of countries, and this is a sort of model that was first created through colleagues in Johns Hopkins that has been tested in many countries, and what through work at WHO has arisen is the element of teamwork. Now, I think that that's really important. It might not sound as exciting as what we consider innovation to be, but there has to be ways in order to achieve that successful teamwork. So there's always a how to everything we propose. And that, to me, thinking in the realms of sort of improvement science is so important. So, for example, there's a lot of great work actually happening post-operatively, but a lot of that has been about building a better safety culture and not just looking at SSI prevention through the lens of the technical actions and clinical practice, but through what we would call the adaptive mode of the culture, that needs to exist.
Right.
So
Right.
the use of tools in a range of countries that can help you understand the current status with your culture, and then being able to identify and look at what would work for you around team working. And recently some colleagues who I know had some funding for a number of research projects, colleagues at Imperial College London and working with others, have just published again on their findings of some surgical research outcomes around improvement that all related to the elements of teamwork. So I think there's a lot to do around that, using the right tools, finding ways like town halls, WhatsApp groups, different ways to make sure the right team can come together. For me, it's a strong innovation that can work in any country.
Very good. I mean, what I'm hearing there, teamwork, collaboration, working together, and not just thinking within your own team. Sounds like the themes are emerging here, not just about the technologies. That's very good to hear. Karen, from your role in the University of Huddersfield and your network, have you come across any examples of innovations recently that warrant sharing or warrant exploration?
I think from what Claire was saying as well, we've got to be careful about using the term innovation as well, because it does cast people think, you say innovation, they think, oh, it must be something that's all singing, all dancing, some wonderful app or a great piece of machinery. I think the biggest innovation in its truest word is teamwork, that people are beginning to realise that if we don't work together, whatever things you've got in place to help prevent infection, prevent surgical site issues won't work. And through this pandemic, I think we've highlighted the importance of the patient really being at the heart of everything we do and involving the family in what we do as well. Because people haven't been able to come into hospital that easily and just walk through the doors as we used to do and sit there for a couple of hours and go home again. People are relying on telehealth or telephone conversations. And also, I think we've got to look at the first point of contact as well for these people who have got a surgical wound, a post-op one. And during the last 12 months, I think it's been the pharmacist that's been that first point. People haven't been, they want to go and see the GP, but it's a dirty place and I don't want to come away with that awful virus, so I'll stay at home, thank you very much. Or I get phoned up by the consultant. But actually my pharmacist is local to me, the pharmacy is local, I know the person that works there, so I go there for advice. So I think one of our innovative ways of thinking, and I'm sure Claire will hopefully support me in this, is we start looking at people like the pharmacist, who in the past we've just seen as, I'll nip down to the pharmacy and get my tablets and I'll come away. And they don't particularly see them as a great source of information, but they're brilliant. And they're doing lots of health education there with the separate rooms that people can go into and learn more. And I think this should be one of our biggest innovations, is ensuring that we work together from looking at first point of contact and the patient and the family, rather than trying to look at really fancy tech things that will be really good, but if you don't understand what you're looking for, that machine's not going to help you.
Yeah, very interesting. Thank you. Any comment on that one, Claire?
Yeah, for sure, Karen, completely agree. And you stimulated me to remember a book that's been out for a long time now, but it's called Turning the World Upside Down. And it really was looking at the those low cost but efficient innovations that can really progress our health systems. Another whole discussion that could be, that I'm sure Karen could talk to much better than me, but our health systems and how they're currently established has to continue to see it much more person-centred. We do talk about it, we use those terms, but I think we have a long way to go when we're looking at that truly being how our systems work. And I think we have that opportunity because of what Karen said around the current situation and how it's made us relook at people throughout the whole journey of healthcare experiences.
I'm just building on that. Thank you, Claire. Just building on that. And we hear that there's an increasing backlog of surgeries as a result of the pandemic because procedures have been postponed for safety reasons, not surprisingly, as well as the surgeons being fully engaged. have you heard of any examples or any thoughts about how that backlog might end up being cleared rather than just try and work longer hours? That's not particularly innovation. Karen, have you had anything on that side?
It's really difficult, isn't it? Because we've got to look at public health is first and foremost as well. And some of your elective surgeries, people are in pain and are having to live in pain, but realise the reasons why they can't go into hospital at this point. I think our private sector colleagues will help out a lot from the NHS perspective and will hopefully allow us to use those beds, and we'll work closer together as well. People have been referred to physio a little bit more, and occupational therapy, for example, to be given exercises to try and reduce the pain and to give them extra aids to help around the house before they can have operations done. But we only have a finite amount of resources, sadly, and we have to look at people that really do need to use these. So sadly, I think the waiting list will continue to be really quite long for a while, but we need to, you never know, we might get more hospitals built and there might be more nurses and doctors that suddenly appear that are fully trained that can help look after these hospitals.
Yeah, it sounds like a tough one. Claire, have you heard anything from around the world in the challenges around there?
Well, again, I think this is where we've got an opportunity, because I think one time where most countries are in the same situation.
Yep,
so we've got another opportunity to learn from each other more than ever before, when we used to say, oh, well, I'm in a slightly different situation to you. And interestingly, what I heard from Karen again was that absolute teamwork, different people being involved in the patient journey that maybe wasn't previously. There have been some recent articles published from the surgical community about factors that will support trying to return to normal surgery schedules that won't necessarily address backlogs. But I think that's an important first step. What are we looking at that will help both staff in surgical areas and patients feel safe going back through that journey in those places, which, as Karen says, have caused a lot of fear around being exposed to the virus. And I think that there's some learning there. I think from my side, I want to give a strong message about the prerequisites that make sure that people can go through those surgical journeys safely, and that's infection prevention and control measures. I think being completely undersold and misunderstood potentially in the last year. We've an opportunity to increase trust and narrative around what does this term infection prevention mean, and to actually again work together to try and build the trust around what elements are needed. And we have to talk about the extra time is needed to actually don more PPE, clean your hands therefore more frequently because of the contamination from PPE. And everyone throughout all levels at national and health facility level just have to be aware of that. And I've got a family experience, a family member who works in a hospital who has told me about the massive reduction in numbers in her service because she has to spread out those appointments. So it's about managers, everyone looking at that and, putting in different business models and talking through, again, how can we be efficient but safe? And again, let's see it as an opportunity to how we can work differently but better going forward.
Very good to hear that.
Rod, can I just
please, of course, yes, yeah.
I think it's really interesting, Claire, because Rod asked us basically about patients and getting them through the system to get your operation done, to get waiting lists down. But actually, we've got to re-educate staff as well and the general public that things aren't going to go back to what we saw as normal 24 months ago, and that there will be longer time between patients. The wards are going to not have as many beds on there, so you can't get as many people through, and making people realise it is safe to come in again, because there's a lot of fear there that the minute you walk through those hospital doors that you're at great risk, especially if you're older or you've got any comorbidities. That's like, I'm going to end up coming in here, getting an infection and never going home again. So we've got to build that trust up again through education, working together and the shared care.
Thank you. Great comments, Karen. Thank you very much. Although we talked about not mentioning technology, I just want to pick up on the post-operative side. And again, it's the perception, and please correct me if I think I'm wrong. On some of the guidelines, and you mentioned there was 29 guidelines within the WHO guidelines, Claire. It perceived that like most of those in the pre-operative and peri-operative phase, rather than the post-operative phase. And the sort of statement is just pop a standard wound care dressing at the end and you'll be fine. But recent announcement from NICE that there is solutions that dressing solutions that will reduce SSIs. So it potentially has this opportunity to change what happens post-operatively. What do you think might be the implication of that? Perhaps I'll come to you, Claire, since this, you're more familiar with all the guidelines, having written them.
Yeah, thanks, Roger. And all those, 29 recommendations. It's quite something to implement, and we have to acknowledge that. So that's my first statement for sure. And yeah, I've already said that I think post-operatively there is a lot of good work, and we maybe don't bring those teams together enough to really piece the jigsaw together. So I think there are some discussions to be had with the post-operative teams more. But in this specific point, from the perspective of new recommendations or new, might want to use the word advice or findings, I think let's put the patient at the centre for a minute as we have this short discussion.
Very good.
So you're picturing the person in the ward area and you're thinking about all of their needs. And I'm sure all of our clinical colleagues do that. It's not just the wound, it's not just the dressing, it's the whole picture. So we start there, but there we are in this ward with that patient and just going to make up a story and say, you've heard or a colleague has heard that there's been a paper or NICE has said, NICE or whomever has said there could be a benefit, and there could be. And I think throughout the pandemic, we've heard those words a lot, right? That's often scared us more than anything else. There could be or there may be, and you're thinking, what does that mean? Same situation. So what we want to think about right away is considering all of the evidence and the implications for the patient. So no unintended consequences, no kind of conducting mini research on your precious patients' lives as they're in your ward to receive your care. Let's look at the package of evidence together. So when we're developing guidelines, we're looking at conducting systematic reviews and meta-analysis, because we have to be sure that actually there's enough evidence and that the quality of that evidence is good enough. So it's great to hear about new work. And if new work isn't conducted, we can't create systematic reviews to be able to create new guidelines and update. Always important, good quality research. So I'm always looking for the next systematic review opportunity so that we make sure the right recommendations go forward for our patients ultimately. So that would be my answer to guideline development.
Yeah, very good comment. Yeah, thank you. Karen, would that be your view as well, or do?
Yeah, there's a lot of evidence out there in the public domain. Google has provided a great vehicle for anybody to be able to just go on and have a look, and Wikipedia. And I would like to say clinical practitioners are able to sort the wheat from the chaff, but sometimes they're not, because it depends how much have you done a module, for example, on how to critically appraise the evidence and how to look at a forest plot and read a forest plot and understand what it means. But we need to, back to education really, explain to people that there's lots of evidence out there, there's lots of wound dressings out there. If you don't treat the patient as a whole, doesn't matter what you put on that wound, it's not going to make any difference. If you're not feeding a patient, if they're dehydrated, if they're in a lot of pain, medications aren't right, then put on it what you want, it's never going to heal. And I think it is about trying to explain that more to some staff members as well, who do think that it is the wound dressing that heals the wound, not everything else that goes with it. And it's quite hard sometimes to explain, because there are lots of dressings out there with some really good evidence that shows that no, you don't need an antimicrobial, for example. You can have a non-medicated wound dressing and that will work against surgical site infection. Yes, it will, but only the patient is hydrated and nutritionally well, and the diabetes is under control. So it's about trying to draw everything together.
Yeah, very good. Thank you, Garen. Okay, we're coming to a close now. So just one last question to perhaps finish off. And today is partly linked to the Journal of Wound Care and World Union Wound Healing Society Awards. Perhaps thinking for many watchers and listeners in terms of the topic that they might submit their entries for next year. Do you have any suggestions or areas where they might want to look and maybe increase their chance of winning, but most importantly, advancing practice? Claire, if you first, please. Yeah.
Okay, I'll try and be concise, and you probably know where I'm going already, because I'm passionate about this improvement science and how do we make improvements happen.
Very good.
So my first call is really to people to know what's out there and not to repeat potentially what we have quite a lot of evidence on already. So to be innovative, we're back to where we started in the thinking around that. My second call is back to where we started at UMA last year. Let's not forget the antimicrobial resistance pandemic. Karen's mentioned going into hospital and the fear of COVID, but we can't forget those avoidable healthcare associated infections that unfortunately happen still in every country of the world. So that's not belittling any of our health systems, any that people who are listening work in, that avoidable infections happen. And some of those are caused by drug-resistant microorganisms. So let's think about putting those jigsaw pieces together again. Let's think about the actual information that we have about how we can go forward with improvement. And you'll remember from before my mantra, we have to think of the little package of 5 elements that mean we can build it, which is the right resources and infrastructure. We can teach in line with the evidence-based guidelines and policies. We can monitor correctly and efficiently for the sake of improvement, that we can remind people what we're trying to do with evidence-based recommendations isn't a test. It's not, can you remember what they all are? It's to support people to do them. And where we talked about at the start about teamwork and that safety culture. So for me, there's an opportunity to look at the WHO guidance, which highlights all the gaps in the research, the implementation manual that goes along with that. And in the post-operative section, for example, there's some action-orientated statements around not prolonging antibiotic use inappropriately in relation to surgical antibiotic prophylaxis. And there's some action-orientated statements about post-operative wound care. So I'd like to see people mapping that all together and looking at an approach within their setting about how they're achieving that joined up teamwork, those joined up actions, and making sure that we can actually not just focus on one part like the wound, but bring everything together. So a call to action to all.
Very good. Okay, good. Thank you, Claire. Karen, your thoughts and suggestions, recommendations to the viewers?
I agree wholeheartedly with Claire. We need to be looking at the evidence. We need to be seeing what people are doing. But I would also like people to be very much aware of when they say they've done something that's innovative in their area, then have some facts at the end of it to show what a difference it's made. So rather than saying, I've done A, B, and C, and it's been wonderful and everybody feels better, where's the evidence that you can show me it has made improvements, and what's the patient thought about it and what the families thought about it? Because sometimes we forget that bit. We say, oh, we've done this wonderful thing, we've implemented this, but nobody ever says, well, did the patient like it? Was it better for them, or was it actually just better for you? So I'd like to see very much more with patient public involvement there, not just as saying it's a tick box. I did involve them. I want them to be involved and to have a voice. That would be nice to see.
Very good. Thank you very much. Yeah, I'd like approval from Claire. Yeah, good. Claire, Karen, thank you so much for your time here and for sharing your thoughts for the listeners and to inspire them about where next to take innovation in surgical site infection. Thank you so much. And see you soon.
let's move on to the Contribution to Clinical or Preclinical Research Award. And this category is sponsored by Bruin Biometrics. I'd like you to welcome to the stage Kate Hancock from BBI.
And so on the shortlist we have Zena Moore, Professor and Head of the School of Nursing and Midwifery and Director of the Skin, Wound and Trauma Research Centre at the Royal College of Surgeons in Ireland. Zena has been working in the field of wound care since 1990, and as the first appointed clinical nurse specialist in tissue viability, she has pioneered the growth of this clinical specialty in Ireland. Zena is a trustee of the European Pressure Ulcer Advisory Panel, where she is also a member of the Executive Board and Chair of the Scientific Committee and a member of the International Guideline Governance Group. And next on the shortlist we have William Tettelbach, MD and Medical Director of Promise Hospital in the United States. Dr. Tettelbach is a certified wound specialist, board certified in undersea and hyperbaric medicine, infectious diseases, internal medicine with formal training in biomedical informatics, whilst also retaining academic appointments at the Duke University School of Medicine and the Western University of Health Sciences, joining the faculty of the Intermountain Podiatry Residency Programme to teach residents wound care, infectious diseases and hyperbaric medicine, as well as the introduction of a hyperbaric medicine fellowship through the collaborative partnership with Duke University Medical School. Dr. Tettelbach is currently the Acting Principal Medical Officer for MyMedX Group and is an active member of the Utah Medical Association Medicare Carrier Advisory Committee. He also sits on the board of the Association for the Advancement of Wound Care. Dr. Tettelbach continues to treat wound care and infectious diseases patients. And the third member of our shortlist is Natasha Menini, researcher at the Department of Chemistry, the University of Florence, Italy. Natasha is a member of the multidisciplinary research team to establish and identify significant clinical parameters and corresponding measurement tests that can evaluate the performance of the main commercial categories of wound dressings in an objective manner. So now for the winners. In third place, Natasha Menini as the bronze place finalist. In second place, Zena Moore as the silver place finalist. And the winner is William Tettelbach, our gold medal winner. Please welcome William Tettelbach to the stage.
Well, thank you. This is very exciting. My name, if you don't really know who I am, is Bill Tettelbach. I've been in wound care for about 20 years, and I've been working to help build the specialty up to impact and elevate, patients' lives. My passion really has been driven by research and direct patient care. Well, I think the most challenging aspect in wound care really today is the fact that it's a multifaceted specialty, but yet it's not just a multifaceted specialty in the clinical sense. I mean, it's also got a lot of sides to it in the sense that it's not a true, at least in the US, a true medical specialty. So when it comes to health policy development, getting that right, working with institutions to understand really the needs of the patients and that it's not really necessarily completely on their radar because they're used to having a clinical program that's defined as a surgical program or a medicine program. So really, and even industry, helping introduce and giving advice to products that are really needed to help with patient care. So that's where I've become multifaceted and was driven by the need to fill voids when I was treating patients directly and still today directly to help influence those decision makers to allow us to do what we really need to do to help the patient. Well, I have to say, again, I'm very honored by this award, and being here today is really not just necessarily achievements of myself. This is, again, a team. It is always a team effort, and I've had wonderful people around me, and I thank all of those who I've worked with in the past and even today. But yeah, this has been a challenge because restricting access in the States, and initially when this pandemic hit, there's now papers out that are clearly showing increased amputation rates, and just keeping us as a specialty a critical need for patients has been a challenge. Well, I think this was just, it's always nice to get it's always nice to get a pat on the back, but again, it's the passion. I mean, my colleagues that I work with, those who've done even more, even won these awards ahead of me, it just helps drive, I think, and give motivation to keep going. And really, the teaching aspect is one of the aspects I love, because I love running into folks that have been past fellows in other states now who are leading the charge in their area and doing it right and being innovative. So yeah, this just, I think, getting something like this, again, it is such an honor, but it helps, I think, keeping us going with a little recognition, because again, this is not the most glamorous specialty in the world.
Welcome to Subepidermal Moisture Measurement, the state of the art, by Professor Zena Moore, brought to you by BBI. Before we start our webinar tonight, here is a short presentation from our sponsor for this evening.
I'm the Chief Executive Officer of Bruin Biometrics, and I've been the CEO since 2012. I was a consultant with Deloitte Consulting before that, all specialized in healthcare. So that would be strategy, mergers and acquisitions, new product development, new product launch. And I joined BBI in 2012, initially in operations, but then moved into the chief executive role. And my responsibility was to take what was called then the SEM scanner and drive that through from essentially what was a concept in the head of Professor Barbara Bates-Jensen, who invented the product, and then push it all the way through the commercialization channels, through regulatory clearance, and into full market deployment. That process took about 5 years. We then got CE marking in 2014, which allowed us to market the product in the European Union mostly. And then we got FDA authorization in 2018, which was the first time that the FDA has actually ever authorized any wound diagnostic device. So that was a real breakthrough for us and actually for the industry. And since the beginning of 2019, we've been marketing the product under the banner of early diagnosis, aiding prevention of specifically pressure injuries or pressure ulcers. And we've been doing that since early 2019. Impact of biometric sensing is just beginning. It's just beginning. So if any of you got an Apple Watch on, the Apple Watches underneath have got those little red lights or green lights, depending on which one you got. And what they do is they're actually measuring physiological parameters. So SpO2, they're measuring heart rate, they're measuring body temperature. That's a biometric sensor. Our biometric sensor uses capacitance, and it comes from essentially aeronautics and space. So that industry had really had a need for biometric sensing way more than any other. So they had been pushing the evolution of these sensor technologies. We're taking them and applying them to the human body. And I'll tell you this much, the amount you can learn from these sensors about the human body we're just scratching the surface, So in our case, we're learning about moisture content down into the dermis at specific anatomies. We have other technologies that look at the ratios of hemoglobin and deoxyhemoglobin, looking at blood flow and quality of blood, which is going to be very helpful in the future in regards to wound healing. There are a whole bunch of other technologies using near-infrared technology, using a green light technology, all these different types of sensors. So I think the short answer is that we don't yet know what we're going to discover, but I'll tell you this much, we're going to know a heck of a lot more about the functionality of the human body in the healthy condition and in the wounded condition in the years to come. Yes, there are actually two of them. Both of them are sort of focused on either groundbreaking research or groundbreaking researchers. Both categories are, to us at least, incredibly valuable. The groundbreaking research, we have actually a colleague in there, I call her a colleague. She's actually a research collaborator, Professor Zena Moore in Dublin. There are obviously two others who are equally brilliant in their contributions. Then there's the Rising Star category, and I have to tell you that one in particular really resonates with me. And it resonates because I love to see new high quality researchers coming into wound care. It's not an area that gets enough attention in my opinion. And what I love to see are these brilliantly qualified, detailed scientists applying their skills in new areas of research. I think it's terrific. So those are the two areas. And as you can imagine, they're both focused on the new, what's next. And so from a company perspective, and actually just from a personal perspective, it really ties very neatly.
So without further ado, I'll hand over to Zena, who will talk to us about subepidermal moisture measurement, the state of the art. Thank you, Zena.
Thank you very much, Kate. I hope everybody can hear me okay. So as Kate says, so thanks to BBI for giving me this opportunity to speak. And it's always a pleasure to hear Amit Geffen speaking. It's like the light at the end of the tunnel for me, because he explains everything so clearly and well. And the beauty is that it's going to fit completely into this presentation here. So with your permission, what I'd like to talk to you about is, why are we interested in subepidermal moisture measurement? What does the existing literature say? And then I'm going to share with you our experience at the Skin, Wounds and Trauma Research Centre, and then just pose a question to you. So now next, what are we going to do? So Amit, this particular diagram is available in the 2016 publication from myself and my colleagues. And really what Amit has shown us is that we are talking about being where we are looking at the damage threshold rather than the manifestation threshold. And what I mean by that is, we're trying to understand what's happening underneath the skin and in the tissues underneath the skin before it becomes visible. Because once it becomes visible, the damage is already there and we can't reverse it. And the problem with staging, and the problem with some of the sort of like campaigns that are out there, which like says respond to red and other sorts of campaigns, is that the main focus tends to be on the skin tissue, even though the underlying muscle tissue may be more susceptible to mechanical loading. And Amit has explained that to us really clearly. So it's important for us to think about the vicious circle that Amit spoke about and keep that in our minds, because when one cell is affected, as Amit talked about, when 4 soldiers are carrying one soldier on a stretcher board, if one of the soldiers is not able to carry that load, then the rest of the cells have to carry that, and they are affected by the virtue of the fact that they are now under more pressure than if they had 4. And I think I always say, when I'm really speaking about how I think and how I focus, is that I didn't always appreciate that I needed to understand the manifestation of what was happening in the deeper tissues so that I would be able to target my interventions more quickly and more effectively. And the problem with grading, as you know from the literature, is that it really is unreliable. And I mean, I imagine what it would be like for you or me if we went into any healthcare setting with a problem, and the people that we saw were only 60% in agreement with what was wrong with us, that there was absolutely 40% of people couldn't really agree what the problem was. That would really not sit well with us in terms of healthcare. So I suppose if you look at this particular slide, it's really saying that lunacy is doing the exact same things over and over, but expecting different results. Now, I've been in wound care since the European Wound Management Association was born back in 1990. I hope you can see that I'm wearing cream trying to keep my skin looking young. But the reality of it is that over that time, you do get an opportunity of reflecting and really thinking more critically about what's happening within our clinical practice setting, really with the drive to be able to say, how can we make things better? And so we really do need to start to think differently. And from the international literature, when we look at the publications around subepidermal moisture measurement, the international literature tells us that higher SEM deltas correspond with increasing pressure ulcer damage. And that when we have abnormal SEM deltas, they are predictive of current, i.e. that the patient may already have a problem, and also future visible pressure ulcer damage, importantly, 1 week later. And also the key thing is that when intervening, when there are abnormal SEM delta, it enables focused preventative strategies to be implemented and reduces the incidence of visual pressure ulcers. And what I mean by that is that if you imagine that when you're carrying out risk assessment on somebody, say me or say Amit, right? I mean, you're trying to identify what Zena's individual risk factors are for when she is exposed to pressure and shear. And you're trying to say, well, is Zena more at risk or less at risk than Amit? Now, when I am at my age, go to the GP and the GP says to you, Zena, you're at risk of hypertension. My GP doesn't just carry out all the risk assessment, in other words, your weight, your age, alcohol, smoking, exercise, and all of that. What my GP does is record my blood pressure and say, is the problem present or absent? And of course, I know one blood pressure monitoring won't give me the answer. You use the monitor for 24 hours and you find out. So my point is the same then when it comes to responses to pressure and shear. The question I ask is, why are we gathering so many questions around risk factors, many of which we cannot modify, to try to understand the individual's potential for response to adverse pressure and shear forces, as Amit has described? When really what would be more useful for us in practice is to be able to identify over weight-bearing areas, how well is Amit responding to the pressure and shear that he is exposed to. We could see that his right heel was okay, his left heel was problematic, but his sacrum was okay, just as an example. And therefore, we would be able to target our interventions to that anatomical area where Amit is showing abnormal responses to the pressure and shear. So at our Skin, Wounds and Trauma Research Centre at the RCSI University of Medicine and Health Sciences in Dublin, Ireland, we have 7 completed studies with 687 patients, 2 in acute care, 2 surgery, 2 in acute care medicine, and 3 in the long stay setting. And we started off with this particular study looking at older persons over a period of time. And we wanted to know, well, what would this SEM scanner tell us versus what does the Waterlow and the Braden tell us? Now, I know the SEM scanner is predictive of presence or absence of a problem, and the Waterlow is looking at risk in the future. But the point we found from this particular study, and you can see from the Waterlow and the Braden, that monitoring that over a 4-week period, over these number of patients, identified to us that there were no changes in these patients, that these patients were static per se in terms of their risk of pressure ulcer development. But what the SEM scanner was able to tell us was that their actual responses to pressure and shear was varying as you would expect. And so we really started to think, okay, so let's move this forward and think a little bit further about it. And we moved on to our second study, which was an acute care surgery, 31 people. And what this particular study demonstrated to us was that as the person came in on day 1, mobilizing, they went to surgery and were immobile. And look what happens to the SEM readings. The SEM deltas increase as the person's immobility increases, and the SEM deltas decrease as the person's mobility then increases, or their immobility decreases. So what that told us was that there seems to be a relationship with immobility and rising SEM deltas, and that we felt was important. So we moved then to our third study and said, well, what could we say was the relationship then between nurses' visual assessment of the skin, so nurses detecting presence or absence of pressure ulcers, versus what the subepidermal moisture scanner would tell us. So acute care, 47 patients, data collected for 20 days. And 34%, so that was 16 of the 47, developed signs of early pressure ulcer damage. And the mean number of days for the nurses to detect the damage was 5, whereas the mean number of days for SEM was 1.1. So the SEM measurement identified this early damage 3.9 days earlier than the nurse's assessment would have done. Now think about that in terms of being able to target the intervention to combat that vicious cycle that Amit talked about in his earlier presentation. So then we went along and said, okay, we have a lot of patients who go to surgery. We know that the incidence of pressure ulcers is quite large when patients are undergoing surgery. So let's see what the subepidermal moisture measurement would tell us versus our traditional risk assessment in adults undergoing surgery. 228 patients, data collected for 3 days, and 52.4% of them were undergoing orthopedic surgery. The pressure ulcer incidence using SEM was 51% and visual skin assessment was 3%. And what we found was that of the people who were followed up for 3 days, that was 66 in total, 94% of them, which was 62 of them, had this persistent abnormal cell delta. So what's the significance of that for us for practice? That would be that Zena comes out of the operating room after having her fractured neck of femur repaired. You are targeting Zena's heels and her sacrum, and you identify that she has a persistently abnormal SEM delta. That suggests to you that you need to target that area with your enhanced preventative strategies before you get to that actual move from the manifestation into the actual pressure ulcer damage phase, as Amit has talked about. So really what this is telling us is that people coming out of surgery will have persistently abnormal SEM deltas. And if, like the 4 army soldiers that Amit talked about, if the area is continuously going to be under pressure and shear forces, you are going to get this continuous vicious cycle of damage, which fundamentally will end up in a visual pressure ulcer if you don't intervene early. And then looking at risk factors and risk screening in the older persons. What I'd like to highlight to you from this particular study, it's 150 patients, data collected for 20 days, using a movement sensor, subepidermal moisture, and visual skin assessment. So the mean movement scores was 121 movements per hour. But if you look at the top box there, the box plot on your left-hand side is healthy people, and the box plot on your right-hand side is the older persons. And what you can see is the variability in the movement data for the older people is much greater than what we see in healthy people. And also the median score in the older people is much lower. Now, what Aglasia, who is one of our PhD students, found was that the pressure ulcer incidence was using visual skin assessment was 12.7%. 6.7% occurred in low movers, but 6% occurred in high movers. And similarly with the SEM scanner, the pressure ulcer incidence was 78.7%, with 40% occurring in the low movers and 38.7% occurring in the high movers. Now, if we were doing the risk assessment alone, we would have classified those who are high movers as being probably relatively okay. But the problem here is that the amount of movement is not predictive of the safety of that movement. And therefore, the SEM scanner is able to help us to identify where problems are arising that you and I may not be fully aware of the potential for happening. And also the key with Aglasia's study here was that the mean time to SEM detection of the pressure ulcer versus visual skin assessment was 6.2 days earlier, giving an opportunity for intervening in this particular case. And so my postdoc, Pinar Afsar from the Skin, Wounds and Trauma Research Centre, also conducted a study in long-term care. She wanted to build on Iglesias' work and to develop an algorithm based on activity and mobility for detecting pressure ulcer risk. Long-term care, 53 people, data collected daily for 4 days using the same mobility movement sensor, SEM, and visual skin assessment. And you can see in her movement results as well, see that massive variability. There's a huge variance in the amount of movements that people are making, with the median being quite low. So 51% of them were considered to be not at risk or mild risk, or 51%, yeah, not at risk or mild risk, according to Braden. Similar to Aglasia, the mean movements was 110, but there is lots of variability. And the pressure ulcer incidence using SEM was 79%, similar to Aglasia, and the visual was 15%. But the key thing as well is that there is almost an even distribution between the low movers and the high movers in terms of the development of pressure ulcers. And that is really important for us in terms of our clinical practice. And so this is kind of like the pièce de la résistance, which is a study that my PhD, Saoirse Byrne, is just in the throes of completing and has given permission for us to share some of her data. It's an acute medicine setting, 149 patients with 2 groups. The intervention group are assessed using mobility and subepidermal moisture measurements, and the control group is assessed using risk assessments and VSA. And the skin bundle is used according to the results of the subepidermal moisture measurement, or in the control group, the nurses use visual skin assessment to increase or decrease the skin bundle. Data collected for 5 days and 43% of them are female. In the SEM PU, in the control group, they're 77.4%, and in the experimental group, the intervention group, 47%. Now look at the mean SEM scores at baseline. In the control and the intervention group, the mean SEM deltas are the same, 0.88 with a standard deviation of 0.42. Whereas in the intervention group, it's 0.88 and the standard deviation is 0.4. So they are the same. Now look at the mean SEM scores at the end of the study. In the control group, it's 0.98, standard deviation 0.35. And in the intervention group, it's 0.49, standard deviation 0.28. So the odds ratio of SEM-PU is about 75% lower in the intervention group than it is in the control group. And the mean difference in SEM delta is 0.49 in favor of the experimental group. So there is a 51% reduction in your SEM scores when you put in your targeted interventions based on the SEM delta scores. And I think this is the first randomized controlled trial that we see that demonstrates this result to us. And I think it's fundamentally important because at baseline, the 2 groups are the same. And the only difference between them is the application of interventions based upon the SEM deltas. Whereas in the control group, the nurses are waiting for changes on the skin surface before they implement or intervene to increase the actual interventions. And you can see the statistically significant differences between the groups when you intervene based upon the actual results of the SEM scores. So that leads us to what next? So the key findings is for us in our research is that all visual pressure ulcers were preceded by an abnormal SEM delta, and that the mean time to pressure ulcer detection is 6 days earlier using the subepidermal moisture measurement rather than visual skin assessment. I think critically, individuals with high and low mobility develop abnormal SEM deltas, indicating that movement alone is not protective in many individuals. And we need to be able to understand an individual's response to pressure and shear rather than focusing on this macro risk assessment. And if you look back to what Kate said back at the beginning, where many of you are starting to use prophylactic dressings, it may well be for that individuals who have high movement, that prophylactic dressings may be of benefit to them to try to combat the shear forces that they're being exposed to. The important thing, and your clinical colleagues will say this to you, is that not all abnormal SEM deltas result in abnormal visual skin assessment. And we see in Saoirse's study that this arises because when targeted interventions are put in place based on the results of your SEM deltas, there will be statistically significant reductions in these deltas, which means that you are combating that vicious cycle that Amit has talked about, and you are intervening before you actually reach the point where there is a visual damage, which is then irreversible. And so they're the key findings for us. And of course, I could be here forever speaking to you about this, but I hope in this short presentation, you have understood where we're coming from and why we are excited about finally being able to see under the skin rather than trying to see in the dark, as it were. Thank you very much.